Welcome to diabetes, a most important topic. During this second section, we will be reviewing type 2 diabetes mellitus. The Standards of Medical Care in Diabetes is published annually and comprises all of the current and key clinical recommendations of the American Diabetes Association for both type 1 and type 2 diabetes. This document represents the official position of the American Association of Clinical Endocrinologists and the American College of Endocrinology for type 2 diabetes. It too is updated annually. This guideline was a little more prescriptive than the ADA and gave more direction, but as of this year, the ADA has become a little more prescriptive. Most physicians do follow the ADA recommendations, so that is what we're going to focus on most. Some of the information given by the AACE is helpful and especially, gives you a different way of looking at things to help understand. The importance of glycemic control in type 2 diabetes cannot be negated or minimized. Good glycemic control is associated with delayed progression of the disease and its associated morbidity and mortality. There are decreased rates of microvascular and neuropathic complications and a risk reduction for cardiovascular disease. The American Diabetes Association has established guidelines for glycemic control in patients with type 2 diabetes. In general, they recommend an A1C, a hemoglobin A1C, less than 7%, a capillary plasma glucose level of 80 to 130 milligrams per deciliter, and a peak postprandial capillary plasma glucose level less than 180. You can see with the asterisk that more or less stringent glycemic controls may be appropriate for individual patients. So you might suggest more stringent A1C goals if this can be achieved without significant hypoglycemia or other adverse effects. Appropriate patients might include those with short duration of diabetes, type 2 diabetes treated with lifestyle or metformin only, long life expectancy, or no significant cardiovascular disease. Less stringent, which might be a hemoglobin A1C of less than 8%, may be appropriate for patients with a history of severe hypoglycemia, limited life expectancy, advanced microvascular or macrovascular complications, extensive comorbid conditions, or long-standing diabetes, in whom the goal is difficult to achieve despite diabetes self-management education, appropriate glucose monitoring, and effective doses of multiple glucose-lowering agents, including insulin. Glucose sticks to the hemoglobin A1C, which is a protein on the hemoglobin, to make a glycosylated hemoglobin molecule called a hemoglobin A1C. Hemoglobin A1C is a lab test that shows the average amount of glucose in the blood over 3 months. It shows how well the diabetes is being controlled. Decreasing hemoglobin A1C levels by 1% may decrease the risk of microvascular complications. For example, diabetic eye, nerve, or kidney disease by 10%. Hemoglobin A1C levels should be checked according to the American Diabetic Association every 6 months in individuals with stable blood glucose.
On this slide, there's a diagram that really helps us to individualize our glycemic targets for patients with diabetes. Again, at the top, you can see a hemoglobin A1C of 7% is recommended for the majority of patients, but that they give the concept of making the targets less or more stringent dependent upon patient characteristics. Starting at the top, patients who have potential adverse effects of hypoglycemia or from drug adverse events, you might consider a less stringent goal. The example might be an elderly patient whose hemoglobin A1C is 7.8, and you're thinking about starting them on insulin. You might be satisfied with the 7.8 because the complexities and adverse events of insulin may be detrimental for an elderly person. Patients with newly diagnosed diabetes typically have a more endogenous insulin secretion, and therefore they're less likely to have hypoglycemia, even in the face of insulin, whereas those with long-standing have very little endogenous insulin secretion, and therefore much more variability and much more risk and higher risk of hypoglycemia. Obviously, controlling glucose is a long-term benefit and does not benefit as much in the short term. So patients who have short duration of action may be appropriate for a higher hemoglobin A1C. Those that have cancer or other health issues that might limit their life expectancy might be appropriate for being less stringent. The more vascular complications of diabetes, the less likely the patient is going to benefit long term, and again are less stringent. Patients certainly are involved in their care, and if they're not invested in taking care of themselves, they are going to perhaps put themselves at greater risk of complications, especially from hypoglycemia. And then finally, we have to individualize our therapies according to the patient's insurance and financial situations as well as other resources. I do want to emphasize that when the ADA published this figure, that they really intended for more stringent to perhaps be down as low as less than 6%, but less stringent to generally be less than 8%. This table is from the Standards of Medical Care in Diabetes from the American Diabetes Association. They've upgraded their recommendations to be more specific and are almost comparable to the guidelines from the AACE. Most professionals use the ADA guidelines, so I would focus on these.
Always start with metformin unless there is a very obvious contraindication. Metformin will still be the cornerstone of therapy, with other diabetes added based on the glycemic goals, side effects, cost, etc. But now the cardiovascular impact of meds will also be emphasized. The SGL2 inhibitor empagliflozin is the first diabetes med approved to reduce cardiovascular death in type 2s with cardiovascular disease. There are others with this effect. Adding empagliflozin to metformin prevents one cardiovascular death in 45 type 2s with cardiovascular disease over 3 years. This med may also slow nephropathy progression. If metformin isn't enough, consider adding empagliflozin, which is Jardiance, by the way, or liraglutide, which is Victoza, in type 2 diabetes patients with cardiovascular disease or at high cardiovascular risk. These patients are often over the age of 60 with diabetes for over 10 years. It's too soon to say if these meds will provide cardiovascular benefits in lower risk patients. Also be aware of some of the downsides. Empagliflozin only lowers the A1C an additional 0.5 to 0.8%, and it costs about $400 a month and is linked to yeast infections and UTIs. Liraglutide reduces the hemoglobin A1C an additional 1% or so, but costs up to $750 a month, can cause GI side effects, and patients may not want an injection. So help all patients weigh the pros and cons of other add-on options. For example, adding a low-cost sulfonylurea or pioglitazone reduces the hemoglobin A1C about 1%, but sulfonylureas can cause hypoglycemia. Pioglitazone can cause edema and heart failure, and both can cause weight gain. Gliptins, or the DPP4 inhibitors, have a low hypoglycemic risk and are weight neutral, but they still only lower the A1C about 0.5%, cost up to $380 a month, and saxagliptin and alogliptin may increase heart failure risk. But continue to add a basal insulin, such as glargine, to metformin if the hemoglobin A1C is 10% or higher, or 9% or higher with symptoms of hyperglycemia. This table shows the effects of the different anti-diabetic medications and their relationship to weight. So you have to consider the risk of an additional weight gain and balance it against the benefits of the agent, especially when we're looking at obese patients who are the majority of the type 2 diabetics. Please note that insulin should not be withheld because of the risk of weight gain. We did not cover the amylin analogs, bile acid sequestrant, or the dopamine 2 agonist, as these are rarely used, and when they are, it is beyond my expertise. I'm not saying that you can't. Heart failure is a frequent and often fatal complication of type 2 diabetes. So choose metformin first for most heart failure patients with type 2 diabetes. Hold if the patient becomes unstable, so if they develop acute heart failure exacerbation. And hold if the eGFR is less than 30, and that's due to a rare risk of lactic acidosis. Preliminary evidence suggests that metformin may improve outcomes, meaning reduced hospitalization and mortality in patients with both heart failure and diabetes type 2. SGLT2 inhibitors are second-line agents. So empagliflozin, canagliflozin, and dapagliflozin have been shown to reduce heart failure hospitalization in patients with CV disease, and canagliflozin in patients with high cardiovascular risk. Be aware that the SGLT2 inhibitors may cause volume depletion in patients taking a diuretic. So do not start an SGLT2 inhibitor if the eGFR is less than 45. And that's for canagliflozin and empagliflozin, or less than 60 with dapagliflozin and ertugliflozin. GLP-1 agonists can be used in heart failure, but do not seem to specifically benefit heart failure. Concerns have been raised about increased heart rate and heart failure in patients in some studies. Sulfonylureas and insulin appear to have a neutral effect. Saxagliptin and alogliptin have been associated with heart failure, hospitalization. Glitazones are associated with fluid retention and increased risk of heart failure and heart failure hospitalization, and should be avoided in patients with heart failure. This is a great graphic of what happens to the hypoglycemia risk when other anti-diabetic medications are added to metformin. So there is less hypoglycemia when a DPP-4 inhibitor is used than if a sulfonylurea or insulin is used. This figure demonstrates the frequency of hypoglycemia with anti-diabetic medications and what percentage of patients that are treated in 1 year with each of the anti-diabetic medication classifications develop hypoglycemia.
This chart is the summary of the anti-diabetic medications for type 2 diabetes. The chart is listed in the required reading, so you have a much larger resource available. It summarizes drug-specific and patient factors to consider when selecting these agents. Trulicity, which is dulaglutide, is the first and only type 2 diabetes medicine approved to reduce cardiovascular events in adults with and without established cardiovascular disease. The others that decrease the risk of ASCVD events in persons with known ASCVD are liraglutide, which is Victoza, and semaglutide, which is Ozempic. With the SGLT2 inhibitors, this chart is not up to date with the latest information. All are beneficial in heart failure, but only empagliflozin and canagliflozin have proven ASCVD benefits in those with known ASCVD. Please note the weight gain that can occur with insulin 2. This would be on top of the level of obesity that most type 2 diabetics already have. The increasing amount of insulin required is directly linked to the rising rates of overweight and obesity.
If the hemoglobin A1C is above target despite recommended first-line treatment and the patient has arteriosclerotic cardiovascular disease or chronic kidney disease, these are the choices. For if the ASCVD predominates, add a GLP-1 agonist with proven cardiovascular benefit, such as liraglutide. It does list this recommendation strangely as liraglutide greater than semaglutide greater than exenatide ER. Liraglutide has FDA approval for cardiovascular benefit as an indication. Semaglutide and dulaglutide also have proven benefits but are not FDA approved as of yet. Or for ASCVD, you can add an SGLT2 inhibitor with proven cardiovascular disease benefit if the eGFR is adequate, such as empagliflozin and canagliflozin. Now, if heart failure or chronic kidney disease predominates, add SGLT2 inhibitor with evidence of benefit, such as empagliflozin or canagliflozin. If they can't take an SGLT2 inhibitor, use a GLP-1 agonist with proven cardiovascular benefit, such as liraglutide, semaglutide, or exenatide ER. There are several options if there is a compelling need to minimize hypoglycemia. So in addition to metformin, a DPP-4 inhibitor, GLP-1 agonist, SGL2 inhibitor, or TZD can be used as an add-on to the metformin. If the hemoglobin A1C is still not at goal, another agent of these same four can be added for a second, or that'd be a third medication. If the hemoglobin A1C is still above target after this, then one of the agents that have a higher risk of hypoglycemia will need to be added, such as sulfonylureas or basal insulin. If there's a compelling need to minimize weight gain or promote weight gain, a GLP-1 agonist with good efficacy for weight loss can be used, which is basically all of them, or an SGLT2 inhibitor, and you can follow the algorithm from there. If cost is a major issue, the sulfonylureas and TZDs or glitazones are the least expensive. This is what the ADA recommends if intensifying to injectable therapies is needed. Again, you have a copy of this under required readings. I'm going to go over a little bit of it on the next couple of slides.
I obviously am a visual learner, and that needs some organization because these tables and figures that are provided by the ADA and the AACE are far superior for me to learn the information. In this figure, if the hemoglobin A1C is still above target despite dual or triple therapy, you should definitely consider a GLP-1 agonist in most patients prior to insulin initiation. But if you do need to begin insulin, basal insulin is usually started at 10 units a day, or you can calculate it to be 0.1 to 0.2 units per kilogram per day, and then you titrate it up. We actually prefer self-titration, and that would be increased 2 units every 3 days. If hypoglycemia occurs and there's no clear reason, then reduce the dose by 10 to 20%. It should be noted that as type 2 diabetes progresses, higher doses of both basal and bolus insulins may be needed to maintain glycemic control. The average daily dose of long-acting insulin used by U.S. adults with type 2 diabetes is 32 units. Approximately 30% of individuals with type 2 diabetes worldwide use more than 60 units of basal insulin daily. The increasing amount of insulin required is directly linked to the rising rates of overweight and obesity. This is the bottom half of that same figure. So once you've added a basal insulin and the hemoglobin A1C target is still above the goal, you may want to add prandial insulin. You would consider this if the hemoglobin A1C target was not reached despite adequately titrated basal insulin, or once the basal dose is greater than 0.7 to 1.0 units per kilogram. Prandial insulin is usually added with one meal first, and it's usually the largest meal. And then you can add stepwise prandial insulin injections of 2 and then 3 injections. Prandial insulin is usually started at 4 units a day or 10% of the basal dose. If the hemoglobin A1C is less than 8%, consider lowering the total dose by 4 units a day or 10% of the basal dose. Then the dose for titration of prandial insulin is to increase the dose by 1 to 2 units or 10 to 15% twice weekly. Now, if you're going to increase the number of prandial injections, you should add another injection every 3 months. This is the algorithm from the American Association of Clinical Endocrinologists. Their A1C goal is a little lower at 6.5%. They are more prescriptive with the order of medication selection. Note the green bars below the medications in each column. These lines are the order of medications and a suggested hierarchy of usage, with the length of the line reflecting the strength of the recommendation. The highlighted green medications are medications that have been shown to have cardiovascular disease and chronic kidney disease benefits. These are preferred in those patients with those complications or diseases. If the patient has coronary heart disease, one of these medications should be used. This is how the AACE recommends managing basal insulin and prandial insulin. It's not that much different from the ADA, but does give you some added information on titration according to the fasting plasma glucose, in addition to the traditional titration schedule of 2 units every 3 days. I will not test you on this material, but feel that you should have the resources.
It was very difficult for me to pick key clinical considerations for this material, as it is all very important. The ones that I have listed here came directly from the ADA Standards of Medical Care for Diabetes, and diabetes will be the heaviest area on the final exam. Thank you for your time and attention. Now, go grab a banana and not that candy bar you were thinking about.